Good afternoon and welcome back, Santa Clarita. You're here with KHTS Radio on the Providence Holy Cross Health Hour. I'm Tom Burton. I'm the orthopedic manager over at Holy Cross, and coming to you every third Wednesday of the month. And here in the station at beautiful Newhall, I am very pleased and very lucky to have two wonderful caregivers and individuals, Tricia Eugenio and Dr. Dortha Chu, who are with us with our cancer program here with Holy Cross in the Santa Clarita Valley, as well as with the City of Hope. And we just got finished talking about the genetic testing and kind of leading into that. And we wanted to go in a little bit more, since we seem to be on breast cancer right now, is this going to be genetic testing going to be something that's helpful in maybe predictability and the such like that?
Oh, absolutely. The honest answer is the vast majority of breast cancers will not be genetic in the sense that that it's transmissible from mother to daughter, et cetera, or actually mother to child. But it is a very important component for those who do have a genetic mutation because their personal risk of breast cancer can be much more significant. In general, any woman, and again, men do get breast cancer. It's just it's so rare. So I'm primarily going to be speaking with numbers with women. But so for any woman, as long as you're a woman, so to speak, with breast tissue, that you have a lifelong risk of breast cancer, roughly around 10 to 12%. But if you have one of the genetic mutations that raises your breast cancer risk, it could go up as high as 70 or 80% lifetime risk. So even though it's still rare to have that mutation, if you had it, it would certainly be very significant. So certainly if you were diagnosed with breast cancer, it'd be important to know if you have a gene or not, because it could change maybe how we would manage your cancer currently as well as future problems. But even if you did not have breast cancer, if you had a family history that would suggest the possibility of genetic risk, I think it's worthwhile to explore that with a physician or genetic counselor these days, because we have that service available now, to see if this is something that you should look into, because it may help, in terms of both your own personal life planning, if you will, as well as there are some preventive in quotes. I mean, they're not necessarily preventive in that I would recommend them for everybody, but certainly for someone who has that higher risk, there are some things we can talk about that could be a risk reducing proposition. And so it is worthwhile to get tested. But it does require someone to sort of be in that mental mode of being able to really go through that process, because it does take a lot of dedication to go through it and a commitment to go through it.
Right. And then now, we always look at the public eye, and not so long ago, Angelina Jolie, I believe, went through some genetic testing and was able to determine that she was someone who was at that very high risk.
Yes.
And just preemptively went through some surgical procedures and such to try to eradicate those risks. And then that would be something that genetic testing, similar to what we would be offering in Santa Clarita.
Absolutely.
With Holy Cross.
Right. Yeah. So we just want to add to what Dr. Chu mentioned. It's not for everyone. It is still a very personal choice, especially when it's out there in the media and was talked about a lot when Angelina Jolie went through the testing. It still requires a conversation with your provider, your primary doctor, if you have a family history of cancer. Whether you're a candidate for genetic testing. Most insurances will cover a genetic counseling appointment if you have a family history of cancer or if you have been diagnosed with cancer yourself. I want to highlight it's still a very personal choice because now that you've gone through counseling and testing and something came back positive, what are you going to do with that result? You will still have to have a provider who's educated enough to talk to you about what to do with all those recommendations, because it's not for everyone. Not everyone will be following through with the recommendation, and if they did, who's going to follow them as far as side effects?
Gotcha. Gotcha. And then and if I remember right from last month when we had the conversation with Monica and with Vivian, I think the discussion sat that depending on how maybe those tests come out, we could make adjustments to our lifestyles, our behaviors, and
Exactly.
the such.
Yes.
That may tilt the scale in our favor a little
absolutely.
bit more. Not that we shouldn't be
Absolutely.
doing that anyway.
Right.
Yeah.
Well, I think that's absolutely true. That's what I mean by sort of life planning. Knowing what your potential risk could be, I think for some people, it helps them to take control of something that's quite scary and it's hard to understand because it's in the media so much, but you don't get that individual, of course, sort of attention when you're just hearing something in the media. How does that apply to you? So I think it's really important to have that conversation. I absolutely second Tricia's comment about the fact that this needs to be a discussion with your provider, both before and after getting tested. Whether you're positive or not for a mutation, it may change how you want to be screened or how you need to be screened, and so it can be a very involved process, and not everyone is ready for it, and you may not even be at a position where you need it. Not just because you have someone in your family with breast cancer or any cancer doesn't automatically mean that you're at risk for genetic cancer. And so it also takes some knowledge to kind of tease that through and say, is this really something you need to be worried about, or are you just within the statistics of bad luck cancer is kind of what I see it as. You just happen to be one of the unlucky ones who developed it or someone in your family did, but it's not necessarily something that you worry about as a family.
Right. Excellent. And then now we do have some diagnostic tools to our avail that are a little bit more commonplace, common practice. And I know that there's been kind of discussion maybe over the last, maybe 5 to 7 years or so, was the use of mammography. It was used a little bit more often, usually with once a year and the such. And then my understanding is that recommendations came down that it didn't need to be performed as often. And then there's been some changes again. Maybe you can shed a little light.
Sure. Absolutely. I think the mammogram recommendations have been in flux and has been very confusing for a lot of people and within the medical community as well. So I'll try to see if I can help kind of make that picture a little bit clearer. Certainly we talked about self-exam earlier, and I'm a big believer, as I discussed, in patients being aware of their own bodies. But the vast majority of breast cancers, we don't want to wait till you can feel it to find it, because if we can find it on imaging, we can actually find it even earlier. And that's really where we've been able to make a big difference in terms of breast cancer survivability, is with the advances in imaging like mammography. The vast majority of breast cancers will develop changes that are visible on mammogram way before it's something that you can feel or see any other changes on the outside. So the mammogram really is the most important screening modality. So even if you don't do self-exam, never have another clinical exam, if you at the very least get the mammogram at the appropriate time, you're ahead of the game as far as being able to pick up a problem soon. Early. But when do you do a mammogram? Now, for many, many years, the recommendation was starting at age 40. All women should start getting annual mammograms. And that was based on a lot of studies that are too tedious to go through. But there was a really good rationale for it because mammogram does find those early cancers. But it is true that a vast majority of breast cancers will be found and will develop after the age of 50. So women between the age of 40 and 50, it's still relatively rare to develop a breast cancer. And so every woman need to have a mammogram at age 40? As a population, the answer is no, because the vast majority will not have a cancer. But of course, for those few who do, could be a lifesaver. So the recommendation now is certainly after age 50, for sure, we recommend an annual mammogram, because it is still the best imaging modality to find them. But between age 40 and 50 is where there may be some flexibility. If you truly have very little risk for breast cancer and you're in that 10% range, then you probably don't need an annual mammogram. And doing one every 2 to 3 years is reasonable. For those who have a higher risk beyond that 10%, then we still do recommend a mammogram every year because it is still, again, the best way to find that early cancer. How do you know, though, if you're in that 10% or more? That's where you have to have a conversation with a physician to make that determination. Right. So it's not a blanket statement anymore. It's a little more flexible, but it's definitely more personalized, and you need to have that discussion.
Perfect. And then so we can utilize our imaging. Maybe we might pick something up. Hopefully not, but hopefully pick something up very, very early on, and maybe spend a little bit of time as far as what type of interventions are available, whether they be non-invasive versus invasive. Maybe you can guys touch on that a little bit.
Sure. Certainly, the earlier we catch a cancer, the more we can do with less.
Nice.
Then what I mean by that is when we're talking about a very small cancer, and this would be the early detection, something that we find only on mammogram or a very small size by feel, typically a patient can undergo breast conservation, meaning that only a small portion of the breast is removed and the vast majority of the breast is not touched. So we can preserve both cosmetically the look of the breast, but also just psychologically not have to damage and cause a lot of scarring. And so that's available when the tumors are small. But the larger it gets, the harder it is to be able to do that. And so that's an advantage to finding cancers early. You'll be able to do less surgery and be able to have just as good effect in terms of cure as if you had a major surgery, such as removal of the entire breast. So it gives you that option. Chemotherapy was something that we started using a lot more because we had some great advances in chemotherapy. And certainly in some cases, when you have a more aggressive cancer, regardless of size, chemotherapy might still be indicated. But the earlier you find those cancers and the smaller they are, the less likely it is that we're going to need to go to the big gun as chemotherapy. And these days, we actually have hormonal therapy, which allows us to target the vast majority of breast cancers that have receptors or antenna, as I call them, for a hormone on the surface. And these come in the form of pills with a lot less side effects.
Excellent.
And so you may not need to have the heavy-duty chemotherapy that we think of, and you may be able to just take a little pill once a day, and
Wonderful.
That's great treatment as well as prevention. So the earlier we find something, the more these options are great, and they offer you that chance at a cure that we weren't able to achieve even a few years ago. Right. So it really is important for that early detection to get all of those advantages that we've been able to develop lately.
Wonderful. And then I see your role as the nurse navigator, that once something is detected, that really puts you into the game where you're
Correct.
Tapped in, because I'm sure that there's a large amount of education, and then also that blank stare that comes up when they hear the C word, that someone's going to need to be able to take a caring hand and guide them in through the processes until such time that they can kind of get their feet back on the ground, so to speak.
Correct. So my role in all of this is to educate and support the cancer patients, especially the newly diagnosed patients. So I'm there to answer any questions. I'm there to anticipate any need that they may have, because it would be like you talking to me about what's wrong with my car's transmission. I would have no clue where to go or what to do after it's been diagnosed. But not to make light of a situation for a newly diagnosed cancer patient, I am the unbiased person working with the patient so that they're not making multiple calls to different providers, finding out basically any barriers in accessing care and helping them through it so that they have all the answers right there and then when they need it. So I'm based out here in Santa Clarita for the Santa Clarita community, and for those who are have any abnormal mammograms, if we're talking about breast cancer and they need some questions answered before they go see a provider, I'm there. If they have any need to access a local or national organization such as American Cancer Society, I can help connect them to a local support group. Connect them like yesterday someone needed a free wig. I gave them the address of the local wig bank here at the American Cancer Society office here in Santa Clarita. So basically just there to support the patient, not only the patient, but also the family and the caregivers, and also working with their providers, their oncologists or primary doctors, making sure they are also appraised of where the patient is at as far as their appointments.
Right. I'm so glad you brought up. I apologize. I just jumped in right. And I saw that mouth opening too. And I jumped right in, anyways.
No, it's all right.
You mentioned something really important. You mentioned the family. And a lot of the times the trying to, and I'm going to use the word manage, and I don't mean it in the negative way, but helping manage the needs of the families as well as the patient can almost be as big of a role, right?
Exactly. So when I've been an oncology nurse for 19 years, and each family has different needs. You can never anticipate it. It's never just one need, because the family dynamic is very different for every patient. And of course, the social situation is very different for every patient. So just having a person that family can call or even just sit down and talk to one-on-one is tremendous. Especially when a patient's newly diagnosed, the focus is on the patient, and the caregivers and the family is kind of in the background. But a cancer treatment can go on for months and years, and it can take a toll on the caregivers. So an oncology nurse navigator is there to help them as well.
Right, and it is a relationship too, really.
Exactly.
I mean, you do form a relationship during that time, and I can see how important it is for you to be that resource person, to be there to help guide, kind of making sure that all the I's are being dotted and the T's are being crossed where necessary. So, amazing job.
I always pointed out to them that I'm the unbiased person, because they get a little confused. You're a Providence Holy Cross employee working out here at City of Hope, and I always point out to them, I'm your nurse navigator working for you, so whatever you need, wherever you need to go, I will put you in contact with that provider or person, or even if it's just emotional support.
You're truly Switzerland.
Exactly.
Nice. And then I just experientially for myself as an outpatient therapist for so many years, when I was at Holy Cross, you mentioned Dr. Ellerbrook before we came on air, and Dr. Ellerbrook was a referrer of mine, because what we found was after having a form of breast surgery and maybe lymph examination, lymph nodes and such, was that it became a difficulty with raising their arms in order to be able to clear enough so they can go through radiation treatments and such like that, and that was something where it was kind of new to me at the time. And when as I delved into a little bit more and trying to think about things, it was really about the fascial changes that can occur with surgery, the idea that the skin has to be mobile over the ribs in order to be able to extend your arm overhead. And then all of a sudden it seemed to make an awful lot of sense. And when I was talking with my class on Monday, that was one of the things is, we're always trying to figure out how do we fit within a care team, and for physical therapists, they would never really take a look at the ideas that we might be the people who are setting up the ability to go through that next level of care. And do you see that still?
Absolutely. Certainly what you're describing, issues with scarring, still occurs. I mean, any surgery, no matter how well the patient does or how well they heal, there's always the risk that there's going to be scar development, and that's the element. There's no control over that, so to speak. And so we just have to deal with, if it occurs, how to make it better and easier for the patient to be able to go about their daily activities. So it does still happen. Scar tissue and and even swelling of the arm with lymph node evaluation can still occur, although they're less frequent these days. And so it's invaluable to have physical therapy support when you have situations like that, both in terms of prevention as well as subsequent treatment if they develop. So I absolutely agree that partnership is so important.
Yeah, it is truly, it really does take a village in order to work on this. And we're going to take a small little break right now. We're going going to come back, just kind of wrap things up, as well as so that you know how to reach everybody, because it's not as much to be able to hear us on the radio. It's better that you actually have the opportunity to be able to speak with everybody in person. So we're going to be coming back in just a few moments. You're with us here on the Providence Holy Cross Health Hour here at KHTS Radio. As we come back, sorry about that. I was going to say something funny before the mic came on. This is Tom Burton, the Orthopedic Program Manager with Providence Holy Cross Medical Center here on the Providence Holy Cross Health Hour on KHTS Radio. And gosh, we've just had a great conversation. It's amazing as you kind of get into it how fast an hour actually goes by. For those of you who are listening, this is actually live, and it goes by just about as quick as you're listening to it. So if not even faster for us who are talking. We have been very, very, very blessed to have Tricia Eugenio, and well as Dr. Chu from Providence Holy Cross Cancer Center here in Santa Clarita in the City of Hope. And we've been really just kind of discussing cancer, but most of it has been breast cancer. And again, I couldn't be any happier to be able to open up today to talk about my friend's late wife, Chrissy Amphlett, from the Divinals, who her song, I Touch Myself, which was so popular back in the 80s and the 90s, has resurfaced as almost an anthem for self-examination for early prevention and detection of breast cancer in Australia, where she was from. And is slowly making its way here to United States. And it only seemed to be reasonable that we would then discuss breast cancer today with experts. Okay, our nurse navigator for the Santa Clarita area, Tricia, as well as renowned breast surgeon, Dr. Chu. Well, it says here, 2015 member of the leading physicians of the world. So it's, yeah, I know, it's fine. Just take it. But you know, we've had a great conversation. One that early detection is a really big deal for prevention and curability. We do know that self-exams should start as soon as maybe we might be mature enough to be able to notice differences.
I like that.
Not anything else, but just really notice any changes.
Yes.
And it is always helpful to understand what normal is first, and that's where our physicians, our practitioners, and caregivers will be able to assist us with that. We do know that mammography is important, especially yearly, 50 on. We know that, however, 40 to 50, depending if there's risk factors, maybe every year, maybe every couple of years or so, seems reasonable. We do know if there's a significant history within the family and concern, you can have that conversation with your physician, and maybe take a look at genetic testing, which is something that is new that we're offering, genetic testing and counseling with Providence Holy Cross. We know that we can treat with targeted chemotherapy, which could be something as simple as just taking a pill. If surgery is necessary, we know that early detection means the less work that needs to be done, the earlier on we can start it. So, it was a great hour to go through, and I need you both to be able to say, how do we reach you? Tricia, how do the patients reach you?
It's very easy. I'm situated in the City of Hope Oncology office across from City Hall. It's on 23823 Valencia Boulevard. You'll see our suite number there is 250 on the directory of the building. But the main number, especially to reach Dr. Chu, or if you ever have a need for an oncologist or surgeon or GYN oncologist, it's 661-799-1999. And I will also give my direct line if you have any questions at all about cancer. My phone number is 626-218-1881. So that's 626-218-1881.
Perfect. And then if you need to reach Holy Cross for any reason, you can reach us at through 888-432-5464. And if it's easier, you can just 888-HEALING, HEALING. Our direct line, 818-365-8051. And we're located between the 5 and the 405 off of Rinaldi, and roughly about 9 minutes for me to get back down there today would be my guess. And I want to just thank everyone for joining us today in the Providence Holy Cross Health Hour. Thank you, Tricia. Thank you,
you,
Dr.
Tom.
Chu.
You're very welcome. Thank you for having us.
And thank you to KHTS Radio, who have been wonderful, staunch supporters of Providence Holy Cross. And we welcome everyone back again, third Wednesday of next month, where we'll be coming back to you with the Providence Holy Cross Health Hour again. Thank you very much.